It's now my pleasure to introduce the second set of speakers. And we have in our midst Professor Chaudhri from King Faisal Specialist Hospital, Saudi Arabia. Thank you so much, Prof, for joining us. Then
My
we
pleasure.
have Dr. Ahmed Ibrahim Oluwaseun from Obafemi University, Ile Ife in Nigeria, to talk about attempting TFR in a resource-constrained setting. We'll start off with Dr. Ahmed. Dr. Ahmed, are you ready? Will you be able to share your slides?
Thank you, Aman. Can you hear me?
Yes, I can hear you.
All right, thank you for the opportunity. Let me share my slide really.
Okay. I think you're a bit faint. Probably you should get near the mic, I think. Yeah. Nearer to the mic. Yeah. Awesome. We can see your slide. Awesome. Awesome. So please let's have your
Okay,
first
can you hear
case.
me now?
Yes, we
Yeah,
can. Yes, we can. So you can go ahead with your first case. Thank you.
in everyone. Greetings from Nigeria. Prof. Chaudhri, you're welcome. Thank you for joining this presentation.
My pleasure. Thank you.
Yeah.
Please go ahead.
Present. So I will be presenting two interesting cases where we had some challenges on deciding to attempt treatment remission in some of our patients. Just to talk about the brief background of the country, Nigeria is a multinational state with more than 250 ethnic groups. And currently, we have about 200 million people in Nigeria. So we have 36 states, as you can see on this map. Fortunately for us, through the DVET International Patient Assistance Program, since 2003, we've been assessed.
Sorry. I think that interpreters are having a problem
You
hearing
need to
you.
come closer to the mic, Ibrahim.
So you need to come closer to your mic.
Sorry, can you hear me?
Yes, your voice is not clear enough, so they are not able to hear you.
Okay. So since 2003, so we have access to Martinique, and some few years ago, so we also had access to other tyrosine kinase inhibitors, courtesy of the GPA program, funded by Novartis and Max Foundation. So currently we have over 2,000 patients, and then although the drugs are supplied gratis, the stress of coming to the few sites that we have has actually been very challenging. And then, as you can see here, so we have two sites currently. We have the one at the capital, that's Federal Capital Territory, and then we have the one in my institution where I work. So imagine patients coming from far away to access Martinique is very challenging. And then to go into the case presentation, so we also have a very low adherence rate. We have adherence rate of about 47.1%. 6 months, this was a study done in 2020 by on about 70 newly diagnosed CML patients on 400 milligram of imatinib. So incidentally, this poor adherence rate observed in this study will definitely affect the rate of patients that will eventually achieve major molecular response and then deep molecular remission, and then this will eventually reduce the number of eligible patients for TFR. Okay, now this from this, we can see that. Then to talk briefly on the available sites for molecular monitoring. So the first one here, that's in my institution, and then the other ones are in the capital. So people living in the rural area will definitely not have access
to molecular monitoring. And again, we have a very poor population with an extremely high exchange rate. So affording some of this molecular testing is very challenging. Now, to quickly go through to the cases. Well, the first case is a 32-year-old German chemical engineer who was referred to our facility. 2016, right, on account of the complaints. The CBC at diagnosis showed anemia, low hemoglobin concentration of 9.6 grams per DL, a markedly elevated white cell count of 123,000, and then a platelet count of 458,000. The peripheral blood film showed features of chronic phase of CML. The BCR-ABL1 transcript done at that time showed E14A2 major transcripts, and then a BCR-ABL1 ratio of 15.6%. So the patient was commenced on imatinib mesylate at 400 milligram precisely March 2016. These are the risk stratification scores at that time. The SOCAL score was the intermediate risk category, while the ASFORD and the ETO score were low risk category respectively. So interestingly, the patient achieved complete hematologic response after just a month of therapy. But sadly, on the 5th month in therapy, patient had grade 3 neutropenia. So add dose reduction to 300 milligram daily, and then further to 200 milligram daily. Unexpectedly, the BCR-ABL1 transcript done 18 months into therapy was high, and tyrosine kinase domain mutation analysis done at this time showed no detectable mutation. So the maximum dose was increased back to 400 milligram daily. All right. Within 6 months on imatinib 400 milligram, the patient BCR-ABL1 had reduced to 0.908% from 1.405 done 6 months earlier. So interestingly, the patient achieved major molecular response within 18 months of recommencing 400 milligram of imatinib, and subsequently achieved deep molecular response after a year. And then this patient has maintained deep molecular response for about 5 years now. This chart, this table shows the sequential, the BCR-ABL1 at diagnosis, and then the current BCR-ABL1 ratio. The treatment-free remission consideration, patient is actually willing to be considered for TFR. However, there is some family dispute here. The wife and then the younger sister, who is a medical doctor, did not support this because they actually expressed their fear of relapse in their relative, and then the fund for the frequent molecular monitoring is a significant challenge. And again, the distance to the site of the molecular test is actually very disturbing. So these are some of the few discussion points that we consider with the initial treatment failure, due which we attributed to the suboptimal dose at that time. Can we consider him for TFR? Then if we are to go ahead with this, how do we solve the family issue if you are to consider TFR? Thank you very much for the opportunity. Prof. Naeem?
Thank you very much, Ibrahim. This is a very nice case, and it's a dilemma. He's a young man. And as far as the TFR is concerned, I think there are few things that we need to consider from the guidelines and the published data. Number one is the patient eligible? I mean, eligibility means that he had, although the response to reach MMR or less than one was a bit lower, but that may have been, as you said, from the low dose of imatinib. But he has remained in remission, deep molecular response for more than 5 years almost, and that's one of the major criteria that shows the success of TFR. No question about this, because the longer the duration and the deeper the response for a longer duration is a prerequisite for that you can expect a better TFR. Now, so I think this patient would be eligible. How would you, second issue for the TFR patient, how are you going to monitor them. I think you have to get away from these guidelines because in resource-filled countries, it would be hard. If he has remained in remission for more than 5 years, you can attempt a TFR. You can do a first monitoring after 2 months. If that is still remains in deep molecular response, and I think you can, instead of going every month, I would go to either 2 or every 3 months from there on. Although the guidelines say every month for the 6 months and then maybe every 2 months for the remaining 6 months. But I think you can modify in the resource construction also because of the expense. You can do it every 3 months if that is possible. The second thing is the family issue. I think that is hard to understand. It has to be a partner decision. He's a young man. He has shown an excellent response. I think it would have been earlier if he had remained on the same dose. I think if it's a partner decision, the family have to understand that he may go back almost 50% of the chance that he may actually go back on the medication. The success rate may be around 40% on him, because I calculated the ELTS score on your patient. It was intermediate because I thought that the patient left abdomen was swollen, so he must have had a very large spleen. So I would attempt a TFR if the monitoring is somewhat possible to avoid for him to go into advanced disease, although the chances of that would be low, and you can catch them. So I would increase the time period for the resource to restrict the waste of the resources.
So can I make a comment with your permission, Dr.
Yeah,
Naeem?
please go ahead quickly. Yeah.
So I 100% agree with you that this patient would qualify in terms of the disease biology for a attempt at TFR. But in addition to just qualifying for a TFR, you have to have a committed patient to do that. If you have a patient who is likely to default in getting the initial testing done, then I would rather not attempt TFR in that patient.
You're absolutely right. That's why I said its resources would be restricted. Yeah.
Yeah, and as we are aware that 80 to 90% of the molecular relapses happen within the first 6 months, I would not, kind of decrease the intensity of monitoring for the first 6 months. We can decrease it in the subsequent times, maybe 3 monthly after the first 6 months. But I would strongly choose a patient for TFR who would be ready and willing to get the BCR-ABL done every month for the first 6 months. That would be, in addition to the biological characteristics of the patient and the inclusion criteria, that would be also an extremely important inclusion criteria for me.
Okay, thank you. Yeah, I think that's reasonable, but in the resource restriction, I mean, in King Faisal, we do it every 2 months. If you look at the latest data is coming out, most of the studies would tell you that 2 months is okay. In the resource restricted countries, you really have to modify out of the box. So if you do it in the first one is done at 2 months, and if you either do it at 2 months or 3 months, and if you remember that these patients really don't go into, they may fail, but the chances that they may go into advanced disease is extremely low. So it's still safe enough if you want to, because as you said, it's $172 for a monitoring, and some people may not afford it, and you don't want him to lose the chance of a TFR if you push him to spend a lot of money. So you really have to make, it's a partner decision, but has to be committed. If it's not done every month, it's okay to do it first one at 2 months and then every 2 to 3 months. That's my recommendation based on what we see and what we do in real life, and also the resource restriction. Is that okay, Ahmed, or should we move to another case? Do you have any comment on this one?
No, I mean, I respect your opinion, but I would, kind of wait for some really solid data to be able to, on a forum like this, convey that to young, impressionable minds. I would be a little hesitant and careful to do that. That's my opinion. I may not be right. Thank you.
Ahmed, Ibrahim, do you have any comment on this one?
Okay, thank you very much, Prof.
Because as you saw, I mean, if the family is committed, you can make a decision. I mean, being a hematologist, if you can always modify this. We do it all the time in clinical practice. Sometimes you cannot follow what the Western countries tell you to do because the resources are different. So it's okay to do, if you can do it the first one at 2 months, and that's the general recommendation, the first one. Then for the first 6 months, once a month, but I think that will be difficult. You can go with it every 2 months, because beyond 6 months, recommendation is every 2 months anyway. So I think it's okay to modify your practice in that way if the patient is committed to you. Next case, please.
Thank you very much. The additional information that I would like to disclose is that from day one, the family has been very supportive. And when it's actually time for us to decide, when the issue of treatment free remission came up, in fact, the wife and then the sister, who is a medical doctor, were very interested. So, now we have two different opinions. The wife and then the sister on one side, and then the patient trying to decide on its own. So, of course, we've tried to bring them together to a roundtable discussion, and then to eventually conclude on what to do. Thank you very much. That's the additional information.
Okay, so I think that's a good point. So we can go to the next case, Ibrahim. Dr. Bena, is it okay? We can move to the next case?
Yes, we can. I think you have to share your slides again, Ahmed. Dr. Ahmed.
Sorry, I'm having some network issue here. So I don't know. Let me try to connect again and share my slide. I don't know if you can share from your hand. It's actually very a shorter case, but let me see if I can. Let me see if I can jump from here. Okay. Okay. I think it's coming on gradually.
And also a point on the previous case while you're doing it. Also, you got the case. Okay, clinical case. Please proceed.
Sorry, Prof, I can't hear you.
Yeah, I can hear you. Please proceed.
Yes, I'm trying to. My network is really bad here. But
no,
I
can see. We can see your slide. We can hear you very well. Yeah.
Dr. Ahmed, are you able to advance your slides? Will you want to try? Move to the next slide.
I don't if.
Or should I
yes.
share?
Let me let me try to continue the presentation with your slide. Okay, I think I'm in now. Okay.
Can you move? Can you advance your slides? Otherwise, you can stop sharing and I'll try and share.
Okay, yeah. Let me continue with your own slide.
Okay, then please stop sharing.
All right. Thank you very much for this opportunity once again. The second case is a 16-year-old male student who was referred 5 years ago from an eastern part of the country. He presented with a 3-month history of progressive weight loss, abdominal swelling of 2 months, and then easy fatigue of 1 month duration. The full blood count done to evaluate the above symptoms revealed a hemoglobin concentration of 10 grams per dl, hyperleukocytosis of 137,000, and a platelet count of 286,000. The peripheral blood film review showed features in keeping with chronic phase of CMM. The RT-qPCR done showed that the BCR-ABL1 was positive with a ratio of 10.9%, and then E13A2 transcript was detected. The patient commenced imatinib at the end of January 2020, and then these are the risk stratification scores. The SOCAL score, intermediate, the Ashford also intermediate, and then the now histio score was high risk. Okay, the patients achieved complete hematologic response within 3 months of imatinib. The full blood count done at that time, they have showed hemoglobin concentration 15.7, normal white blood cell count, and then normal platelet. The peripheral blood film showed absence of blast with differentials of neutrophils 66% and lymphocytes of 34%. The patient achieved major molecular response within 15 months of imatinib with a BCR-ABL1 transcript of 0.02%. So the patient remained adherent on imatinib, 400 milligram daily, but the patient had serious financial constraints. So he could not repeat his BCR-ABL until 2 years after the last test, which was approximately 3 years on medication. By the time we had the opportunity of repeating the BCR, the deep molecular response was confirmed with a BCR-ABL1 of 0.001%. So he has also maintained this for 2 years now. So the latest BCR-ABL1 result is 0.002. So this table shows the BCR-ABL1 results available from diagnosis and then to the last visit. So the TFR consideration here, though the patients adhere strictly to medication, but the patient can only do molecular tests once every 2 years. And this is due to limited finances. Then patient is younger, the young patient, 21 years old. This year, can we consider him for TFR with his age? Thank you very much.
Thank you, Ibrahim. That was nice and quick case. So it's interesting. I mean, I think the man is young, and it's usually the younger who shows a E13, A2. So my point is that if you would like to consider a TFR, he has to fulfill some certain criteria. I think for him, the 15 months of 0.02, probably at 12 months or even earlier, probably he had already achieved an MMR. And the studies have shown in most of the trials and almost of the studies have shown that the patients who achieve an earlier molecular response and maintain a deeper molecular response for a longer period of time, their chances of maintaining a TFR is around 70 to 80%. When you look at the whole cohort, it's about 40% will remain on the long term. But if you tease out these patients specifically, then he falls into that criteria that his chances of remaining in TFR would be very high, because even in second year, beyond second year, he is almost 5 log or more reduction. I think it's maybe, I don't know whether it's a commercial kit or whether the lab has its own kit, because the commercial kit usually does it at 4.5, but it's 5 or 5 more than 5 log reduction. So he fulfills the criteria for being eligibility for TFR for certain. Now, when are you going to do the monitoring for him? I think you have to look at resources, your resources and his resources. You can't go make him bankrupt for sure, and because then he would become a non-compliant and will not do it. I think even if you do it, at least if the first one after 2 months, if it remains in a very deep molecular response, you can do it at 6 months. That's my recommendation to you. This is not based on the criteria, but you cannot follow these criteria of these Western studies. But I think the chance of him breaking off from this would be is extremely low. And if you really want to consider TFR, I think give him a chance. But you really have to modify your practice, and he has to also come up with some sort of idea that he needs to follow your recommendation. At least do it first one in 2 months and then at 4 or 6 months. And if he remains in deep molecular response, you can start doing every 3 months beyond 6 months to avoid financial toxicity on him.
So, Dr. Nadeem, I think
Naeem,
Naeem, like the patient is saying that he will get his next test done every 2 years. Will you permit TFR in a patient like
No,
that?
at 2 years, I think is too much. But I think this is what the physician, the hematologist, and the patient has to come up with. If he's really interested in TFR, then he has to come up with some sort of understanding that he will do it earlier. Obviously, I'm not going to say, okay, 2 years, then go ahead and come back in 2 years. No, that is not, I mean, any physician would not do it. So that's understandable. I'm sure Dr. Ibrahim would not allow that also.
Yeah, I agree with you, sir.
Thank you very much. Thank you. Thank you. I think these cases illustrate what happens in the real world. And I'm sure all of you in the audience have seen one or two cases like that. So we have the lines open now. Kindly raise your virtual hand if you want to ask a question, or you want to put it in the chat, or you want to share an experience. That's fine. I think we can do that for the next 15 minutes. So the floor is open for questions.
So I think I'd like to make a comment with your permission.
Yes. Yeah.
So I mean, I was appalled to hear Dr. Ibrahim's report on the ground level situation in his country, like a country of I think a population of uh,
17
1.7 billion and two centers treating CML. I really truly wish I could do something for the patients over there. And maybe Dr. Ibrahim can tell me if there's something, any way we can help. I would certainly like to do my bit for the patients in Nigeria. I mean, I just cannot imagine a patient traveling to these two centers in the large country just to get their imatinib. So I really wish, I mean, the international community would get together and try to fix that. I mean, my comment is not related to the discussion of the scientific discussion today, but I think I'm very, very concerned about the humanitarian aspects of the situation there.
Yeah,
Thank
let
you.
me ask Dr. Ibrahim, this the the program that supplies the medication. I'm surprised they don't supply medication to all parts, and the patients actually have to travel to get the medication. I thought if they are supplying the medication, they would probably it should be supplied at home through the mail. Is that not the case? That's number one. The second case is if the patient
Hello,
can.
Prof. Thank you for the question.
Yeah. Now, my second point
Yeah,
was the second question also
it's
in the same thing. Can the patient travel to a local hospital and have the blood drawn from a center to have the blood drawn for the PCR able rather than coming to you if you are far away from him? So you can get the results. In that way, he can be monitored. Is that possible?
for now, I think it's actually very challenging because most of the we run a system of healthcare where we have the primary healthcare, secondary and tertiary health care. And then most of these facilities, actually, most of the tertiary health institutions, they are the ones that manage cancers generally. So, and then since the inception of the GPA program, I think the challenge, the issue has been the availability of molecular testing. And from the chart from my presentation, you can see that most of the facility are actually in the urban area, usually in the capital, and then in my hospital here, and the few other ones are in the capital city. So patients patients will have to travel down from their uh, location to this access site. In fact, prior to January this year, the only center has been my hospital here. So patients travel from all over the country to come and access the medication here. But fortunately, the other center was opened, was approved this year, and currently they have over 200 patients there. We still have the bulk of the patients here. So we are still trying to see whether we could open the third center for access of TKI, probably somewhere in the east, so that at least we have a very good location very close to the patient. So it's
Some of these
actually
yeah. Go ahead.
yeah, it's actually a program in progress.
Yeah,
Let me
you can.
quickly talk about the. Okay, Prof, you can go on.
No, I just was wondering this, the pharmaceuticals like Novartis and others who have these lot of these stake in these medications, they can help in the molecular monitoring. They have done it too in other countries where they provide um, the equipment and the reagents to do this molecular monitoring. I think you can approach them, especially for a certain number of patients for who wish to go for TFR, so they can help in monitoring by paying for those tests.
I will appreciate if you can get me some of their link. You can make a trial. I see, because of course we have some eligible patients, but the molecular monitoring has actually been a very challenging situation for
Okay.
them.
So I can suggest
All right,
one
thank you.
thing. There's something known as a dried blood spot testing. Like you
Yes,
collect a
yes, yes.
drop of blood by a finger prick on a filter paper, and this
Yes.
filter paper can then be sent to a reference lab. And the technology is well established now. You can extract enough DNA from this dried blood spot. It could be
Yes, yes,
7 days
yes.
old, it could be 1 month old, doesn't make a difference. You can still get enough DNA from this dried blood spot to accurately test the BCR-ABL. So that might be a way forward in that country. In fact,
How
I was
much?
at Estoril last week for the ICMLF conference, and you can look at mutations in this dried blood spot also.
You're talking about
So
Yes,
digital drop PCR, or you're talking
no,
about
no, no,
different?
no. I'm talking about dried blood spot.
How much
response.
would it
So
Yes,
cost?
yes.
a patient in a village, the physician has to just collect a drop of blood from a finger prick on a filter paper. This filter paper has to be put in an envelope and sent by surface mail to the reference center. And the reference center can extract adequate amounts of DNA from this dried blood spot and give you an accurate BCR-ABL report. And
If
now
that's
this has
not too
gone,
expensive, I think this will be this
it is the
probably can be done.
same charge as standard RT-PCR testing for
So, Dr.
CML
Ibrahim,
in
you
the
can
blood.
maybe look into this on your side if that is availability is there. If
Yeah,
that is available, maybe you can look at this.
yeah, thank you, Prof. Yeah, for that comment. You know, we've actually looked at some of the possible solution to these challenges, and you know, I'm happy that you've actually brought out this very important point. You know, we've actually considered that, but again, some of the patients don't have money to, they don't have the fund to even run the test.
Yeah.
So even if, except, you know, we're actually looking for a way to get possibly a TFR grant, possibly if, because we have a cohort of patients who are ready, who are willing to participate in this, to go
I
on
will
the
try. Yeah,
TFR.
I will try to get some contact from these companies, especially Novartis and others, to see if there is any link they can get in touch with you in Nigeria. Maybe they
All
can
right, thank
fund some of these TFR for these kind of patients, because these
Okay, thank you
patients
very
do deserve
much.
TFR, but of course the financial toxicity can be much on them.
Yeah, thank you very much, Prof. Thank you.
Benet, Dr. Benet, back to you. I don't think there's any question I can see in the chat box so far.
Thank you very much. Very interesting conversations. I mean, apart from the science of it, the practicability of doing some of these things also has some impact on some of the things we can do. And I guess in LMIC, part of the criteria would be being able to do the monitoring. If you can't do the monitoring, you can't do TFR. I think that is
That's the
my
bottom line.
stand. Yes, yes, yes.
But sometimes you have to modify your resources. Hopefully, some of these patients can get benefit somehow.
Precisely, but if you're going to modify, it has to be under stricter monitoring.
Absolutely, absolutely.
Yes. So for the first case, for example, I had a patient who actually was doing fine, hematological remission. After 12 months, still didn't have major molecular response. I just had to keep monitoring. And I think at the 16th month, then we finally got there, had major molecular. So I think that such a person is a slow responder. But then you just don't, it's not business as usual when you're doing that. It has to be frequent monitoring. For me, I would say that if by 18 months the person hasn't achieved major molecular response, then probably it's time to change. And then, of
I have
course,
a comment on that one, Amma.
yes.
In the CML4 study, when they looked at the whole cohort, there was no difference for patients who were in CCR range. That means between 0.1 to 1. If they had achieved that one and they did not achieve a major molecule, there was no difference between patients, except the difference was based on 7 patients only in that study, where they showed a survival difference between a CCR range molecular thing and in the deeper molecular response of more than 4 log reduction. So anywhere in between, there was absolutely no difference. So that's why they keep saying that the gold standard is if the patient is tolerating the medication very well and achieved a CCR range between 0.1, not to change them,
Yes,
because
that's what I'm,
the survival
yeah.
is no different. Yeah.
Yeah, so the aim for me is 0.1.
Yeah.
The rate for me is 0.1. I must say that in our part of the world, our patients present late. So although the person is in chronic phase, it may be a late chronic phase. And so sometimes it's a bit difficult to do certain things, but I think the key word here is close monitoring, especially when you are modifying the guidelines.
And I think the next most important thing is that you have to individualize patient treatment and individualize patient decisions. So many times guidelines just remain guidelines, but you have to take your decisions or at the ground level with the patient in front of you. And individualization has to be done so many times, particularly when you work in resource limited environments, right?
Yep, absolutely.
Thank you. Any comments? I'm sure you've all managed somebody with CML. Do any of the cases discussed today ring a bell? Have you had any similar situation? Did you deal with it differently? Would you want to share your experience? I think we have 5 minutes. Anybody wants to say anything?
Doesn't look like any question, but we all have these kind of patients. I had a patient who was lost to follow. He stopped taking the medication, didn't tell me for 7 years. And he was in deep molecular response. And I used to tell him that you are doing really very well. And I think you should be on TFR. And then he says that I've not taken the medication for the last 5 years.
Yeah.
So these things do happen in real life.
He's one lucky individual.
Yeah.
And there is a whole bunch of patients who go into hematological remission, who go into molecular remission, stop taking their medicines on their own, and then come back with florid hematological relapse.
Yes, absolutely.
Sometimes come back in accelerated phase and blastic phase.
All
So that's
blasters,
the flip side of the coin also.
Yeah, yeah. I mean, TFR, so far as I know, is 50%, 50% chance of relapse. So everybody is different at the end of the day. And so the word individualizing things is very important. And I'm glad you talked about adherence, because I want to remind everybody on the 12th of November, we'll be looking at overcoming challenges with regards to adherence, how best we can deal with it. And also we'll be looking at CML and pregnancy in resource limited situations. I must say this has been very exciting for me, because it shows that no matter where you are operating, some challenges are the same. And I'm sure the cases that have been shared today are not foreign to all the practitioners on the call. So I want to say a very big thank you, thank you, thank you, thank you to Prof. Malhotra, to Prof. Charendran, sorry if I'm butchering your names, I'm sorry.
No, you're fine.
And,
Absolutely.
and then to Dr. Ahmed and to Ephraim. I also want to thank the audience. I think everything has been very clear. And please, these are very, very important discussions. And I think that we should encourage our colleagues to join. And once we can do that, then we'd have a good set of people managing CML.
The CML pregnancy should be a good one, actually. I think the one that you're going to do on 12th of November, that will
Yes,
be
it's
very
going to be
interesting.
very interesting, and probably we'll try and share, and I hope everybody will share how the patients sometimes outwit us.
We just published from our own center 96 pregnancies
Okay.
in ASH last year as an abstract. So we're trying to write it up. So we'll see.
Yes. We've also had, in fact, it's one of my passions, CML and pregnancy, because we see people diagnosed at an earlier age, and once they're doing well, then they start thinking of children, especially because of cultural barriers. So it's going to be exciting. Anyone wants to say anything? Otherwise, we also want to say a big thank you to Nicola, ICMLF. Thank you so much. And to Eileen, a lot of work goes into this. Nicola, I'm sure you are sleepy by now because it's quite early. It's for you. So thank you so much. And I think that I want to say thank you.
Midnight for me also. So thank you, everyone.
Oh,
Oh,
thank
you're
you
still awake
so
and
much.
alive, Nicola.
Thank you all. We really
Thank you
appreciate it.
so much. Thank you. Thank
you for inviting us for this forum. It's always a pleasure to join in the ICML forum.
Yeah, and thank you,
Thank
Dr.
you. Thank you
Ahmed
very much.
and
Thank you.
Ephraim for putting these cases together. So on
Thank
that
you.
note,
Thank you, Dr. Nadeem. Look forward to meet you in person soon.
Sure. Thank you. Nice meeting you.
Okay, thank you,
so on
Prof.
that
Naeem.
note,
Yeah, thank you.
yeah, I wish everybody either a good night or a good morning or a good evening. Until the 12th of November, let's stay safe and let's continue to do what we do best, looking after patients with chronic myeloid leukemia. Thank you.